So just as a reminder, guys, if you're talking, I can't really focus because this room echoes a lot. Remember, you're always welcome to leave. No pressure. Yes, sir? We'll talk it. So you can send me an email. Yeah, send me an email. If you send me an email, you definitely will be on the list. And we'll go from there. The order of when you present, we'll discuss that next week. Yeah, if I haven't returned your email, but I have it, then yeah, you're in there. Yeah. Okay, so when we talk about the pelvis, we know that we're talking about the ilium, the sacrum. So there's technically 3 bones that are associated with this. We also know that the ilium's made up of those 3 different bones: the ilium, the pubic bone, and the ischium. And we mentioned that last week. What we're going to talk about today is the SI joints, the sacroiliac joints that we see there, and then we'll also mention the symphysis joint that we're going to see anteriorly as well. So when we look at the sacroiliac joint, we're talking about essentially the connection between the sacrum to the ilium itself, and its primary responsibility is to transfer the weight from the upper body to the lower body. A lot of times that weight is displaced around the neck or the greater trochanter of the femur, and for that reason we typically see the cortical portion or the outer portion of the bone of the femur as being really dense in that area. The joint itself is a diarthrotic joint. So the SI joint is a diarthrotic joint, but it's really an atypical diarthrotic joint because part of it is a diarthrosis, and then there's actually a part of it that's not. There's also a part that's actually synarthrotic. So the anterior portion itself, we're going to see has that, but the posterior portion that we're going to see, the ilium in contact, is connected by a posterior SI, interosseous, and anterior SI joint, which is fibrous. So we're going to take a look at these different joint types so that we can see sort of the difference between the parts that are ligamentous versus the portions that are actually a true synovial joint. So the anterior and the lower half of the joint is a typical synovial joint. If it's a synovial joint, that means it's diaphragmatic, right? The diaphragmatic synovial joint. That's the anterior portion. Okay. The normal SI joint has a small amount of motion. It's typically 2 to 4 millimeters. How big is a millimeter? It's pretty tiny, right? Like the width of my finger is about 1 centimeter. Okay, so the width of your finger is probably about 1 centimeter. So think dividing this into 10 little tick marks. That's how big that is. Now that motion is pretty insignificant in regards to how much motion we have in our body. But who in here has had an SI joint adjustment? Got it off the table and was like, wow, this is incredible. And it just changes everything. So even though it's a very small amount of motion there, I would say the capacity to interact with the nervous system at that point is pretty significant, especially because it's transferring all of this axial weight to the lower extremity. So it's under so much pressure that even though it's a small adjustment, it makes a big deal. If you were to think of maybe stacking bricks together and one of the bricks was just slightly off, that would throw off the entire rest of that stack. Does that make sense? And by making just the tiniest adjustment, now everything's in a straight line. Does that make sense? Sort of the same thing when we think about our SI joint and the significance it has over the body. Now this can actually change over time. It normally doesn't increase, but sometimes we'll see it decrease. And as we age, sometimes if you're not moving like you're supposed to, the SI joint can actually fuse together. And if you think about it, in medical schools and older research, normally they were using older cadavers to do research. And so initially when people studied the SI joint, they found that they were completely fused together, and they thought that there was no motion in the SI joint at all. We learned that that's not true by evaluating younger cadavers, but we do know that this can change over time, the amount of motion that we can see in there. Now, what kinds of motions can you have with the SI joint? You can have the posterior, if this is the ilium, we can have the joint moving posterior and the sacrum moving anterior, so they move opposite of each other. If it moves anterior, then the sacrum moves posterior. So there's a dynamic relationship between the two, and that makes sense because they're attached to each other, right? If they're attached to each other, when one moves, the other one's got to accommodate that motion in order for that to take place. So I found typically in my office, whenever I adjusted the ilium, I also needed to do a follow-up adjustment on the sacrum, and then it tended to hold on. So sometimes, I don't know if that really comes up in our chiropractic analysis as we're going through. Normally we find like one listing and we just adjust that one thing. But for me, I found that if I did the right ilium, the sacrum, and then opposite on the left side, typically the pelvic adjustment will hold longer. That's my personal experience. You may not agree with that. What else can the ilium do relative to the SI joint? So if these are the ilium, it can also go in, and and then it can also go out. Now, what big muscle is attached to your ilium? Your glutes, right? So if you look at the glutes, you can actually see a difference in the musculature between sides. So if one side of that pelvis goes in, it stretches the glutes out on that side, and the glute will look flat relative to the opposite side. Does that make sense? If the ilium goes external or rotates outward, you'll actually see the muscle shorten, and it'll look like that glute is higher. How do you know which side is the side of a primary subluxation? What do you have to do in order to decide which one might be primary? Because if one is nice and big and the other one's kind of flat and long, how do you know which one is the one you really want to adjust as a primary subluxation? You could do muscle tests. You'll also find that as you get through the program, how to do your different chiropractic analysis, and it typically will indicate which one's the primary versus which one's the secondary. Does that make sense? So it's like we take in the static information we're seeing from the body. We can apply muscle testing to show signs of weakness, but that could be compensatory because the other side is dysfunctional. Does that make sense? Because when we contract our glute, there's actually sort of a false pattern that happens. The back contracts, the opposite glute, and then the back contracts. And so there could be a muscular dysfunction between those, connecting the way they're supposed to, and that might be what the issue is. So again, remember, as you find your findings through either visual, palpation, muscle evaluation, you're also going to add your chiropractic analysis that typically will show you what a primary subluxation is. But what did I tell you just a minute ago? For the primary subluxation, theoretically, if you adjust the primary, everything else does what? Everything else corrects. Okay? I found in my practice, whenever I adjusted just the primary subluxation, aside from the pelvis, it typically wouldn't hold as well, as if I went ahead and did the secondary sort of compensation type adjustments as well too. So again, that's why I'm saying you may not agree with me. You may decide to yourself that no, I adjust the primary, I don't touch anything else, and that's just how I practice. But I would ask you that when you get into practice, if you notice that your patients aren't holding their adjustment for a long time, maybe explore doing the opposite adjustment for the other side as well too, and addressing the sacrum, and then you might bring that back into a more stable thing. But again, you don't have to agree with me, right? That's one of the nice things about chiropractic as a profession, is that as you get out into practice, you can practice the way you want to. Yes, sir? Yeah, typically because the femoral acetabular joint or the femur is attached to the acetabular fossa, as this moves, this also will move as well too. So as it moves into internal rotation, typically we'll see a little foot flare to the outside. As it moves into external rotation, we typically will see a toe-in type of presentation as well too. And it's one of the ways that we can use our leg check to evaluate whether or not there's internal versus external stuff that's happening. You could have potentially a little toe-in or toe-out flare associated with the knee joint as well too, because the knee joint can actually be stuck in external or internal rotation. But again, you'll learn how to essentially discriminate between those two as you go through and do your analysis. The iliolumbar ligament, we mentioned that the iliolumbar ligaments, they attach L4 and L5 to the ilium. And if a patient tells you that they have pain when they're standing, we typically associate that with dysfunction of the iliolumbar ligament. So if you're taking your final exam, and you see a scenario that says, patient presents to your office, you complaining of pain on standing, then we're going to associate that with iliolumbar. Now, is that going to necessarily be true when you see your patients in your office? Maybe, maybe not. Okay? But whenever you're taking a formalized test, you'll learn that some of the phrases are pathognomonic, meaning if you hear this, it means that. So if you're reading a clinical scenario that says patient presents with pain on standing, then we think iliolumbar ligament, even though that may not be true in your actual patient. Does that make sense? It makes sense and it doesn't make sense. But now we know how to answer our test questions so we don't get confused. Now there's other sacro and pelvic ligaments there that we looked at, I believe, last week. We saw our sacrospinous. What's that connecting together? The sacrum and the ischial spine, that's right. And that creates the greater sciatic foramen. And we're going to learn that some structures pass through the greater sciatic foramen in hopefully visceral anatomy, but also in maybe gross too. You'll be talking about the structures that pass through that greater sciatic foramen. Here we just want to know that the sacrospinous essentially creates part of the border that creates the greater sciatic foramen. The sacrotuberous ligament is attached from your sacrum to your ischial tuberosity, right? Now, I just said a minute ago, whenever we're moving our pelvis, so like just from walking, there's sort of like this counter mutation thing that's happening. It's like a figure 8 pelvis. This is like a situated, but this is what's happening with the pelvis. So as the sacrotuberous ligament is being pulled from walking, what's happening is I take a step, my pelvic bone, the ilium on the right side will go into a posterior motion, the sacrum will go anterior. That's going to pull on that sacrotuberous ligament. So if a patient tells you they have pain when they're walking, we can now say they might have a problem with their sacrotuberous ligament. So again, pain with standing, iliolumbar ligament. Pain with walking, sacrotuberous ligament. We said that the sacrospinous ligament, it's going to go lateral, attaching from the sacrum over to the ilium. When you sit down, if you were to put your hands on your ischial tuberosity and you sit down, you'll feel that your pelvis actually opens up a little bit, and the sacrospinous ligament prevents it from going too far. So if a patient tells me they have pain when they sit down, what's happening? The ilium is moving away from the sacrum, and it's stressing that sacrospinous ligament. So if they have pain, what's likely the cause? The sacrospinous. So on our final exam, if we see any of those three scenarios, or we see all three of those scenarios, those are easy points, right? So pain with sitting, sacrospinous. Pain with walking, sacrotuberous. Pain with standing, iliolumbar ligament. We okay with those? Now that conversation will change a lot. You need it again? So pain with sitting.
No, you mentioned the ischial tuberosity. What was that?
The sacrotuberous ligament.
I wouldn't write it again.
Yeah.
So the sacrotuberous ligament is pain associated with walking. The sacrospinous ligament, that's pain with sitting. The iliolumbar ligament is pain with standing. Okay? And we want to know those three scenarios because they do show up sometimes on our EBC test, and then obviously they show up sometimes on our final exam as well. You'll at least get one question about that, if not three. Okay, you could get up to three, and that'd be 6 easy points for us, right? Now again, as you continue your conversation in other classes, you're going to learn that pain with sitting can also be an intervertebral disc issue. You'll learn that pain with sitting could be related to a piriformis syndrome, which is a muscle in our gluteal region. So you'll learn that there's other implicators in here, but typically on a test, if you see these, it's talking about these ligaments if they're in the answer choices. Does that make sense? Hopefully that's nice and clear. The obturator membrane is covering over the obturator foramen. And the obturator foramen is this opening that we see right through here. Now, this is not just a blind opening inside our body. It's covered over by the obturator membrane. It's also covered over by an obturator internus muscle and an obturator externus muscle, which itself is then covered over in fascia. There's a small canal that opens up and allows the passage of vessels. And guess what the vessels are named that pass through that? The obturator artery, the obturator vein, the obturator nerve. So all the vessels that pass through the obturator canal is what it's called. Those are named after what it's passing through. Here we can see our sacrospinous ligament. We can see our sacrotuberous ligament as well. Okay. We don't see the iliolumbar ligament, but we can see these guys right through there. Okay. The SI joint posteriorly has this interosseous connection. So there's this interosseous ligament through here. And you'll notice that there's no joint space. So what does that tell me? That it's a diarthrosis, or is it a synarthrosis? So we're going to learn that the posterior SI joint is actually a synarthrosis where we see that interosseous ligament. There's no real motion that's happening at the ligament except for like the general motion between the ligament itself. But anteriorly, what do we see? There's a joint space, right? So the anterior SI joint is a synovial joint. Now, one of the reasons why that's important is because as we get into our radiology classes, we're going to learn about different types of inflammatory arthritis and arthritis. Different types of conditions will affect different types of joints. Some will affect your synovial joints, some will affect your synarthritic joints. And by knowing which joint is which, you automatically can say, okay, well, this can't be rheumatoid arthritis because it only affects a synovial joint. Does that make sense? And then this can't be maybe psoriatic arthritis because it only affects this joint. All right, so we want to make sure we understand which joint or which parts of the SI joint is there. So again, anterior, we can see a synovial joint. Posteriorly, we can see that it's a synarthrosis. The iliofemoral joint, what's that joining together? The ilium and the femur, right? Nice and easy. The iliofemoral joint is what kind of joint? It's It's a ball and socket joint, which falls under those 6 categories of a synovial joint, and all synovial joints are diaphragmatic, right? Now, it's sort of shaped in some ways like what we see in the glenohumeral joint. Yes, sir? So all synovial joints are diaphragmatic joints. Yeah, so all synovial joints are diaphragmatic joints. You look at questions like that on the final, you want to make sure we understand those joints, right? So again, all diaphragmatic joints technically are synovial joints. Synovial joints have 6 classifications. We want to know what each one of those classifications are. We've gone over a few AKAs, and we want to make sure we know what those are as well too. Now, the head of the femur looks like a true ball, right? You can almost imagine taking someone's femur head and putting it on like a stick shift. Be kind of like a stick shift in your car or something like that. The head of your femur. That'd be kind of cool. I saw a picture of someone's grandmother's remains, and all that was left was her hip replacement, and that was the recommendation that the guy should take it. I don't know if I could do that, but it does sound cool, right? It does kind of sound cool. The acetabular fossa is pretty deep compared to the glenoid cavity. So the comparison we're making is between the glenohumeral joint and the femoral acetabular joint. The glenohumeral joint is kind of like a shallow curve. The femur head is like a nice ball that's got a little net that then connects into the rest or the diaphysis of the femur. Okay? So the femur head goes nice and deep into that acetabular fossa. So there's more stability right off the bat just from that connection. Does that make sense? And then also around the lip of the acetabulum is going to be what? Just like what we saw in the glenohumeral joint. What wraps around the lip of the glenoid fossa? A labrum. We're going to see a labrum deepen the socket of the femoral acetabular joint as well. So again, for that reason, someone can be very flexible, like at the iliofemoral joint, like maybe they can take the leg and put it up over the head, and yet they still have tremendous stability because of the deepness of that actual structure, the acetabular fossa, the labrum creating more, and then of course there's also more muscles that are attaching and stabilizing that joint. So again, we don't see as many injuries from hypermobility in the femoral acetabular joint or the iliofemoral joint for that reason, because it's a more stable joint, even though it still is capable of a tremendous amount of motion. Now, there's 3 ligaments that help reinforce this, and each one is named according to the 2 structures that they connect together. Now, you got to be careful when you look at these, because when you look at them, they all kind of run together, or they all kind of have connections with each other, and so it can be a little confusing. So what we do is we take the proximal portion and see where it connects, and then we look at the distal portion and see where it connects, and then we have the name. The proximal portion of one is going to connect at your ilium. So it's going to be just below your AIS, the anterior inferior iliac spine. And it's going to go over and attach to the femur, so we call that the iliofemoral ligament. It also will look like a upside down, or no, a regular side Y. And so we also will see it sometimes referred to as a bilateral. Your ischiofemoral ligament, we're going to find that on the posterior side. So again, we see the back of the pelvis, we'll see the sacrum, we'll see the coccyx. You'll see the ischiofemoral coming from the ischiotuberous structure. And then pubofemoral, of course, we'll be able to track that over close to the pubic symphysis. Okay, so be close to that superior pubic rami and connect over to there. So if we're looking here, we see pubic symphysis, so we know we're looking at the anterior portion of the pelvis, right? So that tells us this is anterior. If we look over here, we can see this connecting here. And so we can see, first off, this one ligament over this ligament that looks like an upside down sort of V or Y. This is the iliofemoral. You see how it's going just below the AIS? The other one, if we trace it all the way to its origin, is coming from the superior pubic rami and then going to the femur. So that's pubofemoral. And then if we flip it around and we look at the back side, where we see the sacrotuberous ligament, we see the ischiofemoral ligament. Okay. So again, next quarter, or excuse me, in fourth quarter, when you're in your lab classes, you're doing these identification tests where you have to name what these structures are. These are nice and easy. You're kind of hoping you'll get these on your test, because you literally can just look at the 2 structures that connect. You got it. As we move down to the knee joint itself is classified as a hinge joint. And if it's a hinge joint, it still falls under the category of a what? Synovial joint. And if it's a synovial joint, we know it's also under the classification of a diarthrotic joint. Now, there's an anterior and posterior cruciate ligament that cross over each other, and that's typically where it gets the name cruciate. If we see 2 ligaments kind of crossing over each other, whether it's making X or it's making like a cross or a traditional across if you think about, then it's going to get the name cruciate ligament. The one that's in the front, the anterior cruciate ligament, prevents your tibia from moving excessively anterior. Okay, so if we take the leg here and you put your hands underneath my tibia and you try to pull my tibia out like you're opening a drawer, my anterior cruciate ligament prevents you from being able to move it away from the body. Okay? Now, if you look at the knee joint, you can do this on each other later. If you look at the knee joint right here, as you pull, you will see some slight translation here. And you have to be kind of close. You guys maybe in the front, you can see it, but you can see the tibial plateaus. They'll open just a little bit there. That's as far as I can take it. And mind you, I'm pushing really, really, really hard. It's a very strong ligament. Okay? So again, what prevents anterior translation of the tibia? The anterior cruciate ligament. So preventing tibia from moving anterior. Meaning if I suddenly stop but my femur keeps going, it might tear that ligament. Does that make sense? If you take this and instead you go the opposite direction, you take your hands and you try to push it as hard as you can away, this way from you, like you're trying to close a door, that would be stressing the posterior cruciate ligament. So the posterior cruciate ligament will prevent excessive posterior translation relative to the femur, and the anterior will prevent anterior. We call that drawer test or drawer sign. Drawer sign is literally like you're trying to open a door for the ACL, and you're trying to close a drawer for the PCL. You okay with that? So the anterior and posterior cruciate ligaments, they help control agency glide. And then on the side of the knee, we see these two ligaments, just like what we saw at the elbow. There's a medial collateral ligament of the knee. There's also a lateral collateral ligament of the knee. Okay? I'm just using my arm because you can see my arm. Okay? But it's down here, right? You could also call this the tibial or the fibular collateral ligaments to indicate which side you're on. So you could see this written on the medial side here. You can also see that written as the tibial collateral ligament. And then you can see the one on the lateral side also written as the fibular collateral ligament as well too. And you want to be aware of those names. Now that prevents, if this is the femur and this is here, actually we have it still. I guess not. It's in the other one. If we have the femur here and we have the tibia here, those ligaments prevent me from taking the tibia like this and opening it up. If someone had a tear, if this is the left leg, if they had a tear of the lateral collateral ligament, you could take their tibia and you could just do this. Okay, like imagine taking my tibia and just opening it up like that door to the opposite direction. If the medial collateral ligament was torn, then obviously you could pull it away from the body. When that happens, or as that's happening, you're going to see the joint open up. It's really gross and disgusting, just nasty. If it's completely torn, though, will your patient say it hurts? No, because it's completely torn, there's nothing to hurt. Now, if you stretch too far, you may begin stretching the joint capsule. And if the ACL or PCL aren't torn, then you may begin tearing those as well too. So obviously you wouldn't want to just keep going and going and going. Something eventually is going to get, but you will see an excessive opening of that joint. We call that a valgus or varus test. We also just call it a medial collateral or lateral collateral ligament test of the knee. We did the same thing in the elbow, right? The test for that. Now inside of the knee joint, we're going to find our meniscus. And the meniscus is going to be separated into two different portions just based on where it's at in the body. It will either be the medial meniscus or the lateral meniscus. That cartilage is on the superior surface of the tibia, and it's connected by this transverse ligament to the structure itself. And we can say it acts a little bit like a cushion in the knee joint itself. Here we can see, here's the fibula, so we know this is the lateral side. So here we can see our lateral collateral ligament, our lateral meniscus, our ACL in front, PCL in the back, and then our medial meniscus and our MCL. What do you notice here about comparing the lateral collateral ligament to the medial collateral ligament? You see how the medial collateral ligament actually has this intimate attachment to the meniscus on this side? But look at your lateral collateral ligament. Does it connect to the lateral meniscus? This is one of the reasons why when people tear their medial collateral ligament, they frequently will tear the medial meniscus as well too. Because of the mechanism of injury when that happens, it also sometimes will tear the ACL. Because in order for this to be torn, it's going this way and it's stretching and pulling the ACL as well too. So sometimes people will have what we call the terrible triad of Donahue. Sometimes we'll just hear it as the unhappy triad. That's a tear of the ACL, and I believe it's on the slide. It's a tear of the ACL, it's a tear of the medial meniscus, and the medial collateral. Now, you could tear any one of those individually. You don't necessarily have to tear all three of those. So you could have just a meniscal tear. You could have just an ACL tear or medial collateral ligament tear. Okay? But it is also very likely that all three of those will tear together at the same time. Now, obviously, that's going to increase healing time and how long it's going to take to do the rehab of that. If someone has a meniscal injury, we said that the meniscus provides sort of cushion. And if you were to think of it as sort of this very smooth surface inside the knee joint, imagine someone before that, and there's a roughened edge inside the knee joint. As you flex and extend your knee, what's that going to cause? It's going to cause pain. Is it going to allow for a nice smooth motion, or do you think it might be a little uncomfortable? It's probably going to be a little uncomfortable because you have a rough edge actually hitting the cartilage inside the knee. Does that make sense? Sometimes you can also end up with the meniscus actually folding in on itself. And when it does so, as the patient extends their leg, it then will lock into that position and they won't be able to bend it. They will actually have to forcefully unlock it because the meniscus has actually folded over. And it's almost like sticking something under a door, and now the door won't open. Does that make sense? If a patient tells you they have popping in their knee, that might lead you to think that maybe there's a meniscal tear. But if there's no pain associated with it, it's just a normal process. Anybody in here have your knee pop at some point? Right? It pops. It doesn't mean you have a meniscal tear. But if you have a pop followed by a very strong, painful sensation that coincides with the pop, they're both happening at the same time, now we're thinking meniscal tear. Especially if your knee locks up on you. You put all three of those together on a patient scenario, it's like, okay, this definitely sounds like a meniscus tear. Yep. If a patient has instability in their knee joint and it feels loose, they tell you, hey, doc, what it is, my knee feels really, really loose. Okay? And you'll learn later how to differentiate between going upstairs and downstairs with the really different forces on the femur and the tibia. But for now, it's enough just to know that if a patient tells you they feel like their knee is loose, it's likely going to be a ligamentous injury. It could be the MCL. It could also be the ACL or the PCL. Are we okay with that difference? So a meniscal tear would sound like, you know, doc, sometimes my knee pops and I have this really intense pain in my knee joint. Sometimes I also can't get my leg bent after I straighten it out. I'm thinking meniscal tear. If we saw that on our final, we would be able to say that's a meniscal tear. Right? I'm asking. Yes, okay, let's repeat it. So if a patient came into your office complaining of a popping sound in the knee joint accompanied with pain, an occasional locking of their knee, I'm going to suspect that they likely have a meniscal tear, not a ligamentous injury. Does that make sense? So answer choice is a meniscal injury, a lateral collateral ligament injury, a medial collateral ligament injury, or an ACL or PCL. I'm going to choose meniscus. Yes?
Is that characterized by the repetitive popping?
Say that again?
Is that your consistent popping?
So the pop is part of the fold of the tissue. That's its own part, actually moving inside the spindle on itself. As it does that, you can also be getting into the particular surface as well, which is what we call the physical inside the movement.
And would that be
I would say it's indicative of a likely meniscal tear. Until you do your physical exam, you're never really going to say, yeah, this is definitely meniscal tear. Right? So we'll do our physical exam, and then we'll say, based on all the things, all the findings we have, it's most likely to support meniscal tear. You still could be wrong. We really wouldn't know unless you did an MRI that you can actually see the tear. But typically, it's enough to do the support from the physical exam to say, this sounds like a meniscal injury. We're going to go ahead and start rehab as if it is a meniscal tear. If we don't get results within the next month or so, we may send you for an MRI to evaluate. Or if it progressively gets worse, then we can take it back. Yes. So it won't matter for our test. If you get into your other classes, you learn how to differentiate an ACL versus an PCL tear based on pain going up or downstairs. Because as you're moving up and downstairs, you're activating different, or you're stressing different ligaments, and it'll take complete. I don't want to talk about it today, so it's complicated. So keep it simple, right, for now. If you hear popping accompanied with pain and knee locking, we're thinking meniscal tear. If you hear looseness, then we're thinking that it's a ligamentous injury, right? And that's a good start for getting into our physical exams in the knee. This is our terrible triad. One thing we want to know about the ACL is that the ACL has an independent blood supply that runs through this ligament. So if a patient tears their ACL, normally there's immediately swelling. The next day that swelling may actually go away. Why might it go away? If I have swelling in my knee, why the next day might it actually move down to my foot? It's a simple answer. Gravity, right? Gravity is pulling that down. So a patient may tell you, doc, last night I heard this pop in my knee. My knee swelled up like a big balloon, and then I woke up this morning after pressing it all night, and my ankle's really swollen. What do you think's happening? It could be that the ACL tore, initially releasing all that blood, and then kind of moves through gravity down to the lower extremity and got stuck there. If they have a meniscal tear or they have a medial collateral ligament or lateral collateral ligament tear, maybe even a PCL tear, it's possible there may not be any swelling associated with it. There may just be the looseness of the joint. But the swelling in the knee or severe swelling typically indicates some sort of a tear of the ACL. Now you'll learn several different tests to be able to evaluate an ACL tear as you go through this course. Okay, not this course, but in your orthopedic exams. Ankle joint. The ankle joint is essentially where our distal end of our fibula are articulating with the tarsal bone. The tarsal bone is the bone that's kind of hidden underneath your tibia. Okay, so if you look at the ankle joint itself, you'll see that the foot in its normal position, if this were the talus on top, it's kind of hidden or obscured by the tibia. You don't really see it. It is possible that the tarsal bone can move anterior, and that will affect whether your patient can dorsiflex their feet or plantar flex their feet appropriately. We'll talk about that in a second. This is held together on the medial side by what we call the medial collateral ligament of the foot and ankle. It's also known as the deltoid ligament. If you look at it, you can see the names of different bones in there. Tibio-talar, tibio-calcaneum, tibio-navicular. Guess what they connect?
The fibula.
Tibia to navicular, tibia to the talus, tibia to the calcaneum. You'll notice that there's a posterior and anterior tibio-talar ligament because there's an anterior and posterior tibio-talar ligament connecting the tibia to the talus. Okay? Now, collectively, those are known as the medial collateral ligament of the foot and ankle, but you may also see that written as the deltoid ligament. So again, you may see that written as the deltoid ligament. Now, if these are our feet, when someone sprains their ankle, it typically is an inversion type injury. The medial collateral ligament is on the medial side, so as I do this, is this going to stretch the medial collateral ligament, or is it going to compress it down? It's really going to squish it down. So it's not really under any threat of injury from a normal ankle roll. Does that make sense? So normally this ligament's not torn. Okay, so it's on the medial side of the foot and ankle. It's very seldomly injured. In between our tibia and fibula, there's an interosseous membrane, much like we see between the ulna and the radius, that helps anchor these two together to prevent them from separating. Here we can see that medial collateral ligament of the foot and ankle. So we're looking at the medial side. If we were to keep going down, we'll find the big toe. Okay, big toe side is medial side. Pinky toe side will be lateral side. And again, these ligaments, if you look at them, tibia going down the talus, tibial, talar. Anterior, there's also one on the back, so this is posterior. Does that make sense? So if you have a ligament that does the exact same thing in the front and back, you normally just discriminate by saying anterior versus posterior. Okay. Then we have tibio-navicular going down to the sternum of the foot. It looks a little bit like a boat. It's known as the navicular. And then we can see our tibio-calcaneal ligament connecting these two guys together. Now collectively, those are the medial lateral ligaments of the foot and ankle, also known as that deltoid. Now the lateral ligaments are composed of these guys. We have our anterior and posterior taliofibular ligament, talofibular ligament. And you'll see this going from the talus to the fibula. They're very short, they're very close, because the fibula obviously is very close. It's like actually connected or articulating with the tibia. Calcaneal fibular is exactly what it sounds like, from the calcaneus to the fibular. And then anteriorly, the anterior tibiofibular ligament is the one that's most commonly sprained or torn from an inversion ankle roll. Anybody in here ever roll your ankle before? It's pretty common, right? Maybe you didn't roll it to the point that you needed to wrap it, or maybe you didn't roll it to the point that you needed to brace, but you probably definitely been walking and like done this and felt your foot roll in. When that happens, you're carrying that anterior talofibular ligament. We want to make sure we know that. The most common ankle sprain is typically inversion. Inversion means that the foot goes up and in. So if this is the feet, this is inversion. This is the eversion, or the way. Okay? So inversion versus eversion. inversion's going in towards your groin. That's how I remember it, the feet are going in towards the groin. And when you roll your ankle, that's what happened. And that ligament that we see right here, this anterior hyofibular ligament, is getting pulled apart from each other. Now we know that you could partially tear that ligament or you could completely tear that ligament, right? If you completely tear that ligament, you still might be okay in a couple days to walk on it. Why is that? You have all the other muscles that are supporting. Does that make sense? So you still have multiple other ligaments that are providing some stability and support. So it is possible you might still be okay in a few days to walk on it. Is that a good thing or is that a bad thing? It's kind of like mixed. Kind of mixed. You know, when I was growing up, if you hurt something, the idea was don't use it, let it rest, and just leave it there, and it'll get better. And now we understand that if there's no motion happening in that joint, it actually sort of inhibits healing, or it allows for sort of inappropriate healing to take place. So it's actually really good to take something like an ankle sprain, and maybe even that day be walking around on it to create the normal motion. Okay? So the last time I sprained my ankle, it looked like an elephant trunk. It was really big, it was really swollen up. I wrapped it to give it some support and stability, sort of like mimicking the ligament itself. But then, like 10 minutes later, I was kind of walking around to allow that lymphatic drainage, to allow the edema to start moving as well too. And then that also creates a sort of electrical gradient that allows the tissue to line up like it's supposed to. Because remember, we're all chemicals, right? We're all like all these molecules that are inside of our body. And so by creating that electrical gradient, it allows the tissue to heal the way it's supposed to, as opposed to maybe just kind of slowing down the healing processes wherever they're at. So again, motion is actually very therapeutic, but you would want to limit it, right? You wouldn't want to be like trying to walk a marathon or something like that. You may be getting up every hour, maybe like 5 or 10 minutes of walking or something like that. And I likely would use some compression because that would mimic the ligaments holding that structure together so it doesn't fall apart. You know what I mean? Yes? So good question. So let's look at the calcaneofibular ligament. As we move into that internal rotation or that inversion, as this moves up and in, this pulls away from that. This does pull away from this as well too, but the general size and thickness of it is much bigger, it's much stronger, and then also it's the anterior portion that opens up. So normally the back portion through here, it doesn't stretch as far. It's this anterior part that's really doing this. Because the calcaneus is sitting really right under the tibia, so there's not as much motion that's happening. Yeah, I think that you would definitely speak. So if you were to tear this, these two ligaments now have to work harder, right? So I would say that you could see some micro tearing happen in the other ones as well too, and some pain and discomfort as well. Yeah, absolutely. Yeah. So normally when we're looking at a high ankle sprain, it's these guys up here. These guys up here, the interosseous membrane, typically maybe that anterior tibiofibular ligament. These guys are the ones that are getting essentially damaged. You normally can test for that by just taking the fibula, the tibia, and squish it together almost like a sandwich that you're trying to keep big. And then either compression will help you or something where you can release so it won't separate and pull those ligaments, and that'll work well too. But those are the ligaments associated with like height. So the low regular sort of sprain that we think about that happens most commonly is that anterior tibiofibular ligament, but a high ankle sprain would be those ligaments. Now, if you tear these tissues and you allow for appropriate healing, you may be good, no problem, right? What neurological structures are inside of your ligaments that feed information to your brain about where you are in space? Proprioceptors. So the afferent proprioceptors, they send information into the brain about where we are in space. If you damage tissue, the atrophy of that tissue could lead to the loss of some of those proprioceptors. Does that make sense? How many of you in here have torn or had an ankle sprain and then afterwards actually did some training to increase your proprioception in that foot and ankle? Did you do some balance board training? Did you do some one-foot training, like on a foam thing? If you didn't do that, you didn't encourage the regrowth of those proprioceptors, and you may find that you're having recurrent injuries. Does that make sense? But you're losing essentially awareness of where that foot and ankle is, and that's why you're blowing it more frequently. So if you have a patient who comes into your office and is like, man, doc, I'm having the worst day ever, man. Yesterday, rolled my ankle, I mean, it's feeling better today, and blah, 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 and they're telling you about it. You might want to immediately do what? do a physical exam on the foot and ankle, evaluate it, see exactly what's happening, and then maybe give them some therapeutic exercises that they can do to increase stability. Number one, we want to stabilize the joint, but then we also want to increase normal range of motion, and then we want to work with the neurological tissue to help increase that proprioceptive awareness. Because otherwise, they're probably going to have frequent ankle injuries. When I was in my early teens, I rolled my ankles all the time. I didn't know anything about any of this. I just thought maybe I had a bad ankle or something like that, and just kept on hurting it, all the way up into my 30s. And then I got to this program, and I started learning more about proprioception. I was like, you know what? I've never rehabbed my foot and ankle appropriately. I've always just kind of strapped it up and just kind of made do. And I went back and I did the essential rehab training as if I had it, even though I didn't actually have any injury to my ankle, and it completely went away. And I don't roll my ankles anymore. So again, doing that proprioceptive training brings that awareness back to your body. It's really important. And if you've had that happen to you, you can use that for yourself. You literally can just Google some exercises for rehab of an ankle sprain on YouTube. Do those, and you guys will be fine. We okay with these ligaments? Which one's the most commonly torn? If we have an ankle sprain, it's most commonly and it's from a what kind of injury? A inversion. So the feet are going in towards the groin. Okay, so in towards the groin. Now remember, we still have those classifications. We have a type 1, a type 2, and a type 3 tear that could happen. Remember, a type 1 and a type 2 tear means that it's not completely torn, but there's some small tears in there. And in our offices, you should feel pretty comfortable taking care of a type 1 or type 2 tear. You're okay with that. If it's completely torn, though, then we refer out. Okay? So type 3, technically like type 2, 50% or beyond, we typically refer that out. Yes?
Can you repeat which is the most,
An inversion.
yeah. Common kind of tear?
The most common tear is this guy right through here, anterior talofibular ligament. Yes? No, because that's soft tissue, and soft tissue, and it's kind of complicated. But soft tissue technically can show up on an X-ray, especially if you manipulate the factors. You can actually leverage manipulation with the power and speed of an X-ray beam to show you soft tissue, so that you work more and you see it more. But technically, we say we don't see the soft tissue on the X-ray itself. So in order to see a soft tissue injury, you want to see an MRI. There's a lot of research being done with diagnostic ultrasound as well too, because they're so inexpensive and they're readily available. And a lot of people are learning how to use those to actually see the ligaments themselves to evaluate for a tear. Yeah. But normally associated with the location of pain, like there typically will be pinpoint pain in that area as you move into inversion. They'll also have that. You'll see the swelling kind of concurrently in the area where the tissue damage is. And because it's the most commonly torn, because it's the mechanism of injury, we normally feel pretty confident moving forward treating it as it is. The treatment and the things that you would do may not necessarily be different from what you might do if it was a different tear or one of these other ligaments. Does that make sense? So the rehab you're doing might still be specific. The only difference might be if you're doing some laser therapy or some other type of stuff to actually rehab. Again, high ankle sprain is a tearing of the ligaments that connect the fibula and the talus and the calcaneus. We typically think of it as being a little bit higher proximal to there, and we just mentioned that just a minute ago. Now, there's lots of joints and ligaments of the foot that are very thick and they're very strong. I know every time I would be doing a cadaver dissection and I get to the foot, I mean, like I was ready for work. I mean, it was work to get through the superficial tissue and then get to the fascia that surrounds your foot just underneath. Very, very thick. You almost have to take the scalpel and use it almost like a saw to get through some of the stuff. That's how big and thick it is. And that makes sense, right? Because all of the weight is on our feet, right? Every time I take a step, my body weight is swishing my feet down. They're kind of slaying down and open. Our natural tendency for our feet is to have about 10 to 15 degrees of angle between the medial longitudinal arch of the foot and the ground itself. Every time you take a step, that flattens out a little bit. Okay? It shouldn't be flattening out all the way smacking the ground. Does that make sense? So if every time I take a step, like if this is the normal angle of my foot, and every time I take a step, I'm smacking the ground, what's going to happen by the end of the day? What am I going to feel? Pain. What if I'm a runner? And I tell my doctor, hey, listen, I don't know what it is, but 3/4 of a mile, maybe a mile and a half into my run, I start getting a lot of pain in my right foot, just on this inside of my foot. You know what's happening there? It's typically a overpronation distortion syndrome. smacking the ground. And of course, by a mile in, you've smacked the ground how many times? It's a lot, right? So again, that's typically the presentation scenario of that. So again, we're going to see that these joints in the feet, they're very, very strong. But if something goes wrong with them, they cause a lot of pain and discomfort because who's not going to walk, right? Most of us are going to find a way to walk to where we need to go, right? Most of us aren't going to get completely off our feet. Now, these are the bones that we see in the foot. And these bones primarily are gliding joints. Of course, that's a synovial. Of course, a styrofoam. They can be a planar gliding joint. You can also call a planar joint. Remember, you want to know your AKA. So if you see gliding, think planar as well, too. So you could see those written either way. What's another place where we can see those planar or gliding joints? We can see it there. There's another place in the body. In the spine, right? Those facet joints are the same thing. So we want to be able to associate those different classifications of joints. You'll learn technically as you go into like a deeper understanding of joints that they themselves can actually be classified as like atypical. You can see them as modified this, modified that. Normally you don't get that kind of depth though in your MDC test, which is why I don't go into it. You don't necessarily need it. We'll talk about it sometimes, but you don't necessarily need them. This is the medial longitudinal arch of the foot. This is the one that I was just saying that every time we take a step, there's a flattening of this arch, but there's normally still enough space between the foot and the ground for you to stick up to your hip joint, your proximal interphalangeal joint. So if I take a patient and I put them in the seated position, there's no weight really on their feet, right? And so I should be able to take my fingers and put them underneath the medial longitudinal arch of the foot. Now when they stand up, all the weight now is on their feet, right? If I go back and try to stick my fingers in there and I can't, I know they have a pronation distortion, meaning that the foot or the medial longitudinal arch is completely disappeared and I can't stick my fingers in there. Okay? Yes? So in that situation, if they're flat-footed, and this test that I'm talking about, this is a test, it's called rigid versus flat feet, versus flat foot. If you have flat feet, it doesn't matter if you have weight on your feet or not. Your feet are still going to be what? Flat. In the seated position versus the standing position, what are you still not going to be able to do? You're not going to be able to get any of your fingers underneath. It won't matter because they have flat feet. We would call that rigid flat feet. If they stand up in this position and they have flat feet, it's not going to change. But if in this neutral position where there's no weight on the foot, I can see that there's space and then it disappears. We would call that supple flat feet because that means that they're getting a presentation of a flat foot from having weight placed on it. What's collapsing? That medial longitudinal arch. So let's think about one thing. If somebody has flat feet, they're probably having flat feet on both sides, right? And they likely had flat feet for most of their life, right? So if you go in and you evaluate someone and they're like, yeah, I've always had flat feet, there's a good chance that that's not the source of their complaint. So a patient comes in, they have low back pain, they have foot pain, they have hip pain. I'm doing a physical exam, I notice they have flat feet, I ask them about it, they're like, hey doc, I just always have flat feet. I normally can kind of put that, maybe there's some contribution to that, but more than likely, this is a new complaint, right? Why hasn't it been happening their entire life? This is a brand new complaint. It's more likely that it's something else. Does that make sense? So if I have a patient who has true flat feet, their body doesn't actually adapt to that, right? Our bodies have that innate intelligence that will adapt to the limitations of matter that our body has. And so we'll see the development of compensatory mechanisms in the body that allow them to compensate for having flat feet. Does that make sense? If you go in and you start messing with their feet, you may actually cause them pain and discomfort. Does that make sense? So you're going in and essentially messing up a system that for them and their body is normal. And now you're trying to fix it, and by fixing it, you're going to cause them pain and discomfort. You try to give them arches for their shoes, you try to give them custom orthotics, they're probably going to tell you it hurts really bad. And that's normal for everybody, but after about 2 weeks, they're going to say, yeah, this is getting worse and worse. I just had to stop wearing it. Most people with orthotics, they put them in for about 30 minutes day 1, an hour day 2, 2 hours day 3, 4 hours day 4, and you continue like increasing how much you can use them, and the body will perceive that. But if you have flat feet, there's nothing that's going to happen except going in and cutting those ligaments and trying to restructure the feet, which I would argue would be a bad thing. Does that make sense? So again, if someone comes in and they have like true flat feet, I would likely look somewhere else to do this one. Okay? Now, if they come in and one side is completely normal and the other side is flat, what does that tell you? Something's happening. Now there's a formation distortion. It could be that maybe somebody dropped a heavy thing on the foot. Maybe they're an offensive lineman and the linebacker blitzed, and like when they did, they stomped on that guy's foot as hard as they could with their heel, and then had so it could be a traumatic injury actually caused a collapse of the foot. We're also going to learn that on the anterior part of the tibia and on the posterior part of the tibia, we have these muscles, the anterior tibialis and the posterior tibialis, and they run underneath the foot and they support that medial longitudinal arch. So it's possible that they have a weakness of one of those muscles that's causing the collapse. We can tell that sometimes by having someone do a squat or an overhead squat, because as they increase the stress on it, you'll see the foot flatten out. And you'll learn how to do a functional analysis as you guys are going through the program so you can see distortions like that. In that situation, the appropriate thing to treat would be the muscle. Does that make sense? Normally, if I have someone who has any of those scenarios, I'm still adjusting, number one, because where misalignments in the foot cause as a result of that issue, more than likely. So I still adjust the foot, but then we do the rehab exercises as well, too, to support and stabilize the foot. Anybody here ever have your foot adjusted? It's amazing. It feels incredible. The first time I had my foot adjusted, I was the dummy for our lower extremity class. I just came up as the mannequin. They used my feet because they're huge, and so they're like everybody will be able to see it. And they only adjusted one side, and I didn't think anything about it. But later that day, I just happened to be going out for a 10-mile run. Okay, I used to love running when I was here. It was like my therapy. And so I was running, and I think about like 2 miles in, it felt like one side, the side that had been adjusted, felt like it had like an AC unit. It felt like it had people fanning my foot. It was running so smooth. I was like, wow, this is really great. And the other side felt like death. It felt like my foot was on fire, like literally fire. It felt like people were poking it with pitchforks. And I went back to the teacher. I was like, listen, you had to adjust this other foot. That was horrible. That was like the worst experience ever, which I'm so thankful I had, because I never would have realized what an impact it had. And it really wasn't anything special. When you guys go to your lower extremity adjusting classes, you're going to learn how to adjust the foot. You're going to think nothing of it. You're going to be like, oh, this doesn't really matter that much. Unless you have an experience like I did, and then you see it. When I first got into practice, I happened to notice on my patient's subjective information that she had some foot pain. I asked her about it. She said, yeah, I've had that foot pain for the last few years. No one's really asked me anything about it because it was like a subluxation-based office. They just took care of it fine. They didn't do very much extremity work. I went in, I adjusted the foot. I did exactly what I had been trained to do. I didn't think anything about it. The next time I saw that woman, she came up to me and she like broke down in tears because she was able to go to sleep pain-free for the first time in her life. I mean, I couldn't believe that adjusting her foot doing like nothing. I didn't do anything special except read that there was an issue there, and I took care of it. That was it. And she was literally in tears. It was really a humbling experience to understand what a huge impact. But think about that. I mean, what are you walking around on every day? You walk. Your feet, right? So again, the amount of benefit you can have to your patients by adjusting the lower extremities is pretty important. If you don't want to touch people's feet, I understand that. If you don't want to touch people's feet, but it sounds like they have a foot problem, what do you need to do? You need to refer out. It's okay if you don't want to do it. Okay? It's your office. You get to decide what you do and you don't do in your office, but you are under an obligation and responsibility to make sure they get the care they need. Does that make sense? So if you don't want to do it, that's fine. If you have an aversion to it, I suggest us getting some gloves and just not worrying too much about it and just move forward. I had a friend of mine who I came through the program with, and he was like 4 or 5 feet. I mean, he would break out in sweat. He had gloves. He'd get to the foot exam, and he'd go, okay. And he'd be shaking. He'd start sweating, like you could see it, and then he would go down and touch these feet. I didn't know what was happening. It was really scary. So I doubt that he touches feet in practice, okay? But I'm sure he refers out if he sees a patient that could benefit from something like that. Now, all that to say, the medial longitudinal arch is the one that typically flattens out, but it does work in symphony with the transverse arch, which goes from lateral to medial around our talus bones. And then there's also one other one, which is our lateral longitudinal arch as well. The lateral longitudinal arch isn't typically as implicated as much because it actually is in contact with the ground. It's kind of like where the angle is made from the ground to the angle of that lateral arch. And then it flattens out on the medial side across the transverse. There's a lot of ligaments that support the foot, and that makes sense. We need lots of ligament that supports the foot. The first one we see here is this plantar fascia. The plantar fascia is this very, 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 very thick fascia that is immediately underneath the skin of your foot. Okay? You dissect the skin of the foot, it's not really all that deep, and you hit something so hard, you're like, I can't get through this. It's the plantar fascia. You guys ever heard of plantar fasciitis? Yeah, plantar fasciitis. It's a pretty common thing. It's not important. It's not uncommon for people to experience, especially if you're a runner. You might have experienced it at some point. That plantar fascia kind of helps hold your feet together. And as we go out through the day, it is possible that you could be doing some micro damage to that fascia. When you go to bed at night, what do your feet do? What position are your feet? Are they in dorsiflexion or do they go into plantar flexion? They go into plantar flexion. Well, if I have a ligament on the bottom of the foot connected from the calcaneus to these tarsal bones here, and I go into plantar flexion, what does that do to the ligament? It shortens. So overnight, as that micro trauma begins to heal, it heals in a what? Shortened position. Imagine having a scab at an elbow joint and you have to send your elbow and it pulls apart that scab. That's what happens to people who have plantar fasciitis. Overnight, as the healing process takes place, it's almost like tiny little scabs happening inside the fascia. And then they step out of their bed in the morning, the foot splays open, and all of those little healed spots tear apart. And if it's bad, they typically will tell you, doc, when I wake up in the morning, it literally feels like I'm walking on broken glass. So I start to kind of move my foot around a little bit, kind of get towards the shower, it loosens up a little bit, and then it starts feeling a little better. By the end of the day, though, it's right back to where it was in the morning. It doesn't feel like I'm walking on broken glass, but it really, really hurts. That typically is a pretty good scenario indicating this is plantar fasciitis. Does that make sense? How would you treat it? You can treat it by using special socks that actually will keep the foot in dorsiflexion. Sometimes I've seen that help. I've seen orthotics help. Orthotics help people sometimes because it gives them some support and stability where there's already weakness in there. It's almost like wearing a brace for the bottom of the foot. My most effective treatment was when I would adjust the foot. I would then go in and I would trigger point out the muscles that support the arches of the foot, the anterior and posterior tibialis muscle. And then I also have the patient get orthotics before we do. Or we at least examine the footwear they have. Because technically I would change the footwear first before spending $100 on orthotics, right? But you got to wear shoes, right? Maybe you don't need orthotics. Okay? Those typically were the most effective treatments. Sometimes it could have been one of those three things, and maybe that would have been fine. That would do all three every time we one after the others as well. Okay, the only thing I normally would hold off is making them paper stuff. Yeah, what's up?
When you're running, what's the best way to run? Some people tell me to put an in on your balls or your feet. What's the best way to do it?
So when you take a step, when you're walking, every time you're walking, you're hitting your heel, right? When you're running, that's not necessarily what you're doing, right? When you're running, you're typically like moving forward momentum, you're doing toe off and push off of your foot. So the entire foot's still in contact. So really like getting into the mechanics of running, it may change based on your body type, foot type, but I would say there's a standard sort of approach to it that you can see. So getting into like the mechanics of that maybe is beyond what we do today. We'll talk more about it if you want to. The long plantar ligament is going to be deep to the different muscles. So essentially, like we remove the skin, we see this. We then come to muscles of the foot, and then underneath it, we find the long plantar ligament intimately associated with the bones of the foot. So this is over the top of bones. This is actually on the bones. There's then a short plantar ligament, which connects the calcaneus to the cuboid bone. It's really, really short. It's just beside the long plantar ligament. And then we have the spring ligament, which is on the medial side of the foot. We have the spring ligament, which is here on the medial side of the foot. If you look at it, it's also known as the calcaneonavicular ligament. I kind of like that thing better. Even though it's really, really long, it tells you exactly what it's connected to, right? Calcaneonavicular ligament. It tells you exactly where you can find it. You can find it in between the navicular tubercle and this structure here known as the sustaintaculum tali. The sustaintaculum tali kind of sustains the talus. You can think of this little support stone that helps anchor the talus in place. We okay with these ligaments that we see through here? Remember, the plantar fascia is the most superficial, implicated with things like plantar fasciitis. Deep to all the muscles, we find the long and short plantar ligament, and on the medial side of the foot, we're going to find that calcaneonavicular ligament, also known as the spring ligament. Yes?
So when you were saying, so plantar fascia is important over everything, and
Yes.
the long plantar, short plantar,
Yeah, so like it's connecting bone to bone. So the fascia technically is connecting bone to bone still, the plantar fascia, but it's very superficial. And it's the first thing you'll see underneath the skin of the foot. I really like extremities a lot, just because you can see so much impact from taking care of the extremities. See, these guys right through here, transverse metatarsal ligament. It's exactly what it sounds like. It's going transverse, connecting our metatarsal bones. The deep transverse metatarsal ligament is just deep to the one that we see is the superficial, really. And then we have this muscle called the peroneus. The peroneus muscle is better called fibularis because it's on your fibula. So you most likely will see this word in the future written as the fibularis, technically longest and brevis. It sits on top of the fibula. The brevis goes in, attaches to the styloid process of our fifth metatarsal. So the fifth metatarsal has a little styloid process. Let's see if we can see it here. See this little sort of protrusion right through there? That's where the peroneus brevis will come in and connect. The peroneus longus will go from this lateral pinky toe side and then wrap around down here to the base of the first and second metatarsal. So peroneus longus, peroneus brevis are also idral stabilizers that will go underneath the foot and stabilize the foot. How are we doing with the joints of the lower extremity? You feel okay? Let's take a break there, maybe about a 5-minute break. I'll pull quickly back up for you. I'll also pull up the instructions for what to do next week if you're preparing to do the presentation. Remember, all you needed to do was email me that you wanted to do that, and we'll get you squared away. Yeah, what's that?
Yeah. Yeah, that's the one thing.
Yes.
I looked up.
Oh, cool. Yeah, what time?
It said because I either
Maybe the ilium is like kind of low, but maybe you still have.
yeah, I haven't been able to find anything what's mixed. But it does say like either or.
Okay. I've actually seen some heights on this.
Yeah.
That's the big portion of it.
Yeah.
That's so interesting. Actually, I left class last week and I was like, wait, there was something I was able to look up. I don't remember what it was.
Yeah, I didn't really break it, but I definitely want to look at like
It's so
actually go
fascinating.
into it.
It's so cool.
Yeah.
Maybe that could be easier though, or either way.
Right. Yeah.
Maybe like get it around the support of this. So let's go ahead and go back. Let's first I'm just gonna go over this year's project for next week for those of you who are interested in doing that. The project itself has a couple of different functions. It's really not meant to be an English experience for you. It's meant to be an opportunity for you to get a chance to do some public speaking. Remember, as a chiropractor, you can be amazing. You can be a phenomenal doctor. You can actually be the best doctor in your neighborhood or in your state, or maybe the country. But that really doesn't matter. If when you talk to people, they can't connect and resonate with you, they'll just go somewhere else where they do connect with a person, even if that person's a worse doctor. There was a guy who came here and talked one time, and he said, yeah, you may be a better doctor than me, maybe you can get better results than me, but I promise you I can out-talk you and out-sell you every day. And I thought that was the most disgusting, despicable thing I've ever heard, but it's 100% true of business. And unfortunately, it does determine essentially a portion of your success, especially if you're going to go into your own practice. So part of that opportunity to do this is to give you chances to speak. And so I would say if you're nervous to do it, you should definitely do it. The other thing too is that I don't get a lot of free points. Like there's not a lot of free points, and that's basically what this is. This is you getting up here for 3 to 5 minutes and maybe stumbling over a few words, maybe you make a mistake here and there, and then you get 5 bonus points. Okay? So again, don't miss out on that opportunity. I had 4 students, at least 4 students last term, who failed the class because they didn't do that. Okay? So again, do the presentation, even if you're nervous to do that. It's a good opportunity to get those bonus points, and if you're scared, you should definitely do it. The other thing too is that it is to give you an opportunity to start researching what's the importance of the structures we're learning. It doesn't help us to learn all this anatomy, where it's at, if we can't actually see and understand its implications in our practice. If you can't leverage this information to give you better patient outcomes in the future, then it's really kind of worthless to learn it, and I would argue we should remove it from the program. Does that make sense? So again, there is a reason why we learned this already on that. This is all you have to do. Next quarter, when you're in gross 1, I'm going to make you do the same thing for gross 1 structuralist that we do in the 4th quarter. Now, this quarter, you may have used a method that didn't work very well for you. So the first slide is meant to expose us to other ideas of how to do the project. So your very first slide is just going to be, I utilize Notability to prepare my presentation. I went in week by week. That was my strategy. I kind of got lost week 4 because all the midterms hit up, and I kind of got back to it week 6, and I was able to complete it by week 7, just before the deadline. And this is the strategy I used, and this is maybe what I would do differently next quarter. So it literally should take you more than a minute to share those things. We move to number 2, the anatomy that you're going to actually discuss. If you wanted to discuss the glenohumeral joint, and then maybe talk about the anatomy of the glenohumeral joint, you can then go into a pathology, or even just an interesting fact about the glenohumeral joint. It doesn't necessarily have to be disease or something like that. It could be some other process. Slide 4 is just going to be an image. So if you choose an injury, you just provide a picture of that injury on there. It could be a drawing. It could be something that you stole from Google. It doesn't matter. That's fine. And then your 5th slide should be your summary. Again, the entire thing should take you somewhere between 3 to 5 minutes, depending on how fast you present. Okay? And we should have time for everyone who wants to present. questions about the project itself? Remember, you could also talk about the clavicle. The clavicle is one of the first bones in the body to begin to ossify. It's also the last bone to ossify completely. It's also our easiest bone to break. It takes about 8 pounds of force to actually fracture the clavicle. It also is one of the only bones to develop via intermembranous and endochondral ossification, which we'll talk about in a minute. So you could, if you wanted to, talk about the development of the bone. You could talk about rib treatments. If you had a chiropractic influence, you could choose to decide, like talking about an L5, S1 adjustment that you really like, using maybe a Thompson drop table or something. You can do that. So remember, it doesn't necessarily have to be pathology. It's just really just to kind of get us thinking, like, well, how can I correlate the information I'm learning here into what I might future do in practice, either in clinically identifying pathologies or maybe just something that you're going to do. Like, what's a leg check and how does that work? Just remember, it's only going to be like a 1-minute discussion, so don't get into like the philosophy of like the technique and this and that, because it'll be too long and people won't get to present it. We okay with that? It's pretty basic, straightforward. Yes, sir?
After sending, even if we want to present, do we also send you a presentation?
No, you don't necessarily need to send me a presentation. I will say last quarter, let's use this way too. If you send me the presentation, we might be able to quickly pull it up from the computer and just use my login information, as long as I can access your presentation. Last quarter, we ran into an issue of trying to get people's presentations up. Some people emailed it to me, but then they still had to use their login information to get access to the presentation. So if you wanted to send me like a true copy of your presentation that we could open, we could do that. I might even at the beginning of your class have like a sign-in sheet, like the order that you want to present as well too. Just know that if you've told me you want to present, you definitely have the opportunity to present. Does that help clarify that? But yeah, maybe would email me a standalone copy of the presentation. If you bring your computer, we might be able to quickly switch it. We do have the ports up here to like plug in your computer and pull it up directly on the screen, as long as it's working the way it's supposed to. So you could send me a copy, also bring your computer when you try those methods. Yes, ma'am?
Can you do screen share of your presentation?
You could, you could. Yeah, I mean, any format that can get it up here on the screen, that's all I care about. Any other questions? No? What we're going to do now is we're going to take a sort of U-turn back into what I believe is our week 6 information and take a look at bone growth and bone development. This presentation's only about 30 slides. You minus the pictures, probably really like 25 slides. Back around week 1 or 2, we talked a little bit about the histology of bones, which did encompass a little bit of talking about the development of bones. So some of these may seem like pretty familiar topics, but then again, that was week 1, so who knows? Okay, seems like a lifetime ago. The first thing we're going to do is talk about intramembranous ossification versus what's known as endochondral ossification. Endochondral ossification typically happens in bone bones, and we'll see that in just a minute. Intramembranous ossification typically is what we're going to see happening in flat bones and irregular bones. So irregular shaped bones and flat bones typically develop through intramembranous ossification. The bone itself is forming directly on or within the loose fibrous connective tissue membrane. So I sometimes think of it as like a bag that you might get at Walmart, and like that bag slowly begins to ossify from the center and then moves out. So again, intramembranous ossification happens as this sort of process within the membrane that slowly ossifies. Now there's 4 basic steps compared to 5 basic steps of endochondral ossification. So we typically say that intramembranous ossification is a simpler method to form or harden the cartilage that we have. The 4 stages, and we want to know these 4 stages, we have the development of the ossification centers. We have the calcification of the membrane itself. We then have the formation of the trabeculae. And then we also have the development of the periosteum as the last portion of it. Now, each one of these steps are spelled out for us here. Okay? So the very first step we had was the development of the ossification center. You can see that here. Ossification center. Osteoblasts begin to differentiate, begin creating essentially the bones around it. So osteoblasts begin to calcify. The matrix secretion stops and then hardens, and those cells are called osteocytes. Because remember, when an osteoblast matures, it's known as an osteocyte, right? Osteoblasts are capable of mitosis. Osteocytes are not. Right? So osteocytes are mature bone cells that originate from an osteoblast. In step 2, the lacuna, remember lacuna are like the little lakes where we find the osteocytes, and the caniculi are found or formed. The caniculi, remember, are little canals where the extension of the osteocytes essentially reach through and communicate with the other cells inside the bone. We okay with that? Second step. Step 3, we have the formation of the trabeculae, the inner portion of the bone itself. And because we have trabeculae, we should remember that this is spongy bone, right? Remember, we had an osteon system, and then we had a trabecular system. And so this type of ossification, or intramembranous ossification, uses the trabecular system. Don't forget, the trabecular or the osteon system, the base components were all the same. It still had lamellae, they still had lacuna, they still had osteocytes, they had all of those structures. It's just they were organized on a macroscopic scale differently into the spine. The blood vessels begin to grow into those spaces. This is important because we need the blood vessels to bring in the nutrients, and then red bone marrow is formed by the end of that stage. Stage 4, we get the development of the periosteum. The mesenchyme, which is the origin essentially of this process, at the periphery begins to condense into the periosteum. And remember, the periosteum is the outer portion of the bone that connects. There's an inner portion of periosteum that's attached to the bone, and then there's an outer layer of periosteum. The inner layer is where we find things like our osteoblastic cells, because that's where bone growth will begin to happen. The outer portion is where we find more of our nociceptors, like our pain receptors, but we don't find things like osteoblasts on that outer layer because there's no bone transformation happening. Does that make sense? So on the inside of that periosteum, bone growth is still happening, but on the outside of that periosteum, there's no bone growth happening, so we don't find those cells. Now, the bones themselves start off one way and then they continue to develop. And we're going to see that the bones of the skull start off very incompletely grown together, and that there's those big fontanelles that separate the different areas to allow for the collapse of the skull as the baby passes through the vaginal canal. We'll revisit that as we get to those structures. Now, the second type of ossification we're talking about today is endochondral ossification. Endochondral ossification is said to be the more complex of the two different ones, primarily because the initial stage is the development of this bony model. So when we see this cartilaginous antigen that we see here, it really is the formation of what looks like maybe a plastic model of what's going to eventually become a skeleton. Does that make sense? So it's like you make a model of a baby skeleton out of plastic, and then you slowly begin to change that plastic into bone from the inside out. Okay? The bone sort of takes over, and then as we mature, the bone continues to grow in size, and then also in shape. Now, there's 5 stages that we see. Now, this is for long and short bones. So the other one was irregular and flat bones. We want to make sure we know that. Irregular and flat bones develop via intramembranous ossification. Endochondral ossification is how we form the long bones and the short bones. Okay? Long bones and short bones. Remember, short bones are essentially another way of saying like those cuboid type bones or cube-shaped bones that we see in the tarsals and the carpals. So step 1 is going to be our development of the cartilaginous antigen. Okay, essentially from mesenchymal cells. Now, if you don't know what mesenchymal cells are a type of embryological tissue that essentially initiates the process of bone formation. So we're going all the way back to our initial development. The mesenchyme develops around this thing called the control tube, and then it starts to move peripherally and begin to develop a skeleton that surrounds essentially our spinal cord and the brain. So again, this originates from our embryology topics. And these mesenchymal cells, if you don't know exactly what they are, that's not necessarily the worst thing in the world. But we might want to review something maybe on draw if you know it. Maybe you guys can access that through the library website. You can access that for free. You can go to embryology, and you can look that up. And you can see maybe a 3 or 5 minute presentation so you understand what we're talking about. We used to have a complete, total standalone embryology class, but there just isn't enough information, or there's not enough testing material in the national course of just having a standalone class. So again, we kind of give you the nuts and bolts, and if you're kind of feeling overwhelmed by that topic, I would encourage you to go to drawer. So what we need to know here for this class is I need to know that this first step in endochondral, I'm on the first step. So this should be endochondral ossification. So this is a mistake, I'm sorry. This doesn't remember this. The development of that ossification center is where we see the mesenchymal cells. Mesenchymal cells, so please fix this. Please don't miss that. I'm so sorry. I don't know how that happened. Intramembranous ossification, this should be endochondral ossification. Cross that out. Endochondral. So from our mesenchymal cells, we get our osteogenic cells. Remember, osteogenesis means the formation or pertaining to the formation of bone cells. From these osteogenic cells, we get the osteoblastic cells. Osteoblastic cells are what secrete that bony matrix. Here we can see step 1, 2, 3, 4, and 5. Step 2 is essentially the growth of that cartilaginous model. So you created a cartilaginous model or a baby skeleton. It now needs to grow a little bigger because initially it's just too small. So it begins to grow. And then as we get to stage 3, we're going to see the development of our primary center of ossification. Primary just means that shows up first, that's all. So when we have our primary curve of the sign, kyphotic is the first curve for a given sign. When we have our primary ossification center, it literally just means that it's the first center of ossification happening in that bone. And we see it develop inside the diaphysis. So in the shaft of the long bone, we see the development of the primary center of ossification. That shaft is also known as the diaphysis of the bone. We've already talked about that. The model itself will grow in length. When it grows in length, that's interstitial growth. If you remember inter, the prefix inter means between 2 points, right? So interstitial growth means that we're growing between 2 points, which means the bone is growing in length. Does that make sense? Appositional growth looks a little bit like an apple to me, and apples are big and fat, right? This is when we're growing in circumference. So as the bone gets bigger or wider in circumference, we're talking about appositional growth. So I remember that by thinking of a big apple, and that lets me know that this is growing in width. Maybe in diameter is a better way to say it. And interstitial growth is growing in length. The chondrocytes that we have in there, remember cytes means cell. Chondro just means cartilage. So these are cartilaginous cells. Begin to hypertrophy. And hypertrophy just means they do what?
Waste
They
away.
get bigger, right? Like muscle hypertrophy means that the cells you have are getting bigger. They're not creating more cells. You're just making the cells that you have bigger. So hypertrophy means the cells that you have are getting bigger. Some of these bursts, and that increases the pH that we see inside the cell, and then that triggers calcification or the process of calcification. Some of the other ones die within the matrix, and that's what forms the lacuna in the actual cells themselves. And later in the lacuna, we'll find the osteocytes, right? So later in the lacuna, we'll find these osteocytes. Now, our third step is going to be the development of that primary ossification center. We're going to see a nutrient artery penetrate the perichondrium, which essentially is the periosteum later at the end stage. So it penetrates through the bone, goes into the central canal, and begins to supply all that's needed in there, forms of nutrients. Again, inside the diaphysis, we see that. This stimulates the osteogenic cells in the perichondrium to begin to differentiate into those osteoblasts. And remember, osteoblastic cells, they build bone, like we're going to blast our biceps, we're going to make them bigger, right? Osteoclastic cells are catabolic, bless you, and those are going to destroy things, right? And break down bone. So here we can see the development of that primary center of ossification. And in stage 3, we're going to see the development of that primary ossification, as we just mentioned. And then the perichondrium becomes periosteum. Perichondrium, chondro means cartilage, right? Periosteum means bone. So the cartilage is being replaced by bone in that center, or in the outer portion of the bone. Stage 4, we see the development of our secondary centers of ossification, and that happens in the proximal and the distal epiphysis. Remember, the epiphysis is either end of the bone, specifically our long bones. The center portion of the long bone is the diaphysis. The diaphysis is the primary center of ossification because it shows up first. And then in stage 4, we have the development of these secondary centers of ossification here, happening in the epiphysis. So proximal epiphysis, distal epiphysis, depending on which bone we're looking at and where it's at. Now, from this point, we're going to begin to see differentiation of these cartilaginous cells as they begin from proximal to distal, or here, distal to proximal, going towards the center. So as they move towards the center, these cells are going to start to become bone cells. We'll talk about that progression of growth in just a minute. So again, that fourth is the development of the secondary centers of ossification. Stage 5 is the formation of the articular cartilage that we see at the epiphyseal plate. The epiphyseal plate is what we see as the growth plate. The growth plate is something that we're concerned about maybe for, let's say, like a 9-year-old girl or boy who's doing maybe gymnastics. They fall off the beam and they break their leg. One of the first things we want to evaluate is that epiphyseal plate, because if damage happens to that epiphyseal growth plate, that bone will no longer grow. The other bone is still fine, right? And so now this bone's growing the way it's supposed to. This one is stunted in growth, and now there's going to be a very severe leg quality. Does that make sense? If you're planning on using leg checks in your future office, you need to know if your patient has leg length inequality, like a true anatomical difference, meaning that my right leg is 2 inches shorter than my left, and I wear maybe an orthotic to actually fit that discrepancy. Because otherwise, if you lay the patient on the table and you look, you're like, man, you're always right left. You're always right and short. You're always right and short no matter what happens. You'll learn that you still can use that leg length inequality, but you just need to know that this is the starting point so that when you see the legs balance out, it's not that they balance out, it's that the right leg actually has more. Does that make sense? So again, you can still use it for leg length checks if that's what you're doing in an analysis, but you want to be aware of any anatomical discrepancies. Yes, ma'am?
So at what age is it not so much as a concern being
So typically, depending on if it's male or female, normally around 18, 20-ish, we're not as worried about it because normally those growth plates have finished growing. Most of us, by the time we got maybe to high school, we didn't grow very much. Some of us got to college and then we grew another 3 or 4 inches. So it could be that this bony growth is still continuing into your early 20s, but for most of us, when did you stop growing? You know what I mean? Some people maybe stop in 9th grade, 10th grade, or something. Yeah. So it could be in late teens, early 20s. You still would evaluate though, right? It wouldn't really matter. If I had somebody who's in their 20s or something like that, I'm still going to evaluate to see if there's any damage to the growth plate. Now this is cartilage, right? This epiphyseal growth plate is cartilage. So if you were to look at it in an x-ray, is it bone? No, right? It's a simple answer. It's not bone, it's cartilage. So when you looked at it, what would it look like on an x-ray? It would look like a black line separating the epiphysis from the diaphysis. Does that make sense? Because it's cartilage, the x-ray beams will pass directly through the tissue, hit the film, increasing what we call radiodensity, which is just a way of saying it'll be blacker in that portion of the film. Does that make sense? So again, when we look at this on the x-ray, we'll actually see that this is sort of separated from the epiphysis and diaphysis. If it looks nice and even, we know it's on it, there's no damage that's happening to it here. The next thing we might be worried about is if there's any neurological damage as well too, and then we might go in and do like a dermatome and a sensory evaluation, and then finally we do a muscular evaluation to make sure the muscles are okay, starting from least invasive to most invasive. Right? Here we see that epiphyseal growth plate, and again, remember if you're looking at a developing skeleton, it's going to be perfectly normal to see what might look like a fracture of those epiphyseal plates. How do you know it's not a fracture? Because of the age, location, and it'll also be on both sides. Okay, it also will be on both ends of the bone. Now, as this plate closes, it'll leave the remnant known as the epiphyseal line that we'll see through here. Now, this is a closed growth plate. That bone's not growing anymore. Epiphyseal growth plate. Now, bone begins growing in utero and then continues throughout our entire life. Yes?
Where you see like
And normally that's where you see it. So and it depends on which bone we're talking about. So the humerus has the head, has an anatomical neck, and then has a surgical neck. Most of the other bones don't have that. Like your femur doesn't actually have a surgical neck. When I initially took over the class, it was like on the list of whatever kind of stuff that we had. And I looked it up. It's actually essential. But that is going to be here because when you see it, the femur kind of goes in the shape of that bone. There's different kind of places we'll see. So bone continues to grow your entire life, right? We said that bone is a living, dynamic system that's responsive to stress. It doesn't grow in length your entire life. Does that make sense? So the density of your bone can increase or decrease. The amount of bone that you have can increase or decrease, but the length of those bones will not increase. Does that make sense? If you were to have something like surgery to heighten yourself, like let's say you're like 4 foot tall, it really bothers you, you could have surgery. Some people will see as much as 6 inches of decrease as a result of doing that, and maybe for that person that's really significant, and they really want to do that. And then for other people, obviously, maybe the pain and everything associated with it's not worth it. So you can't have surgery to increase your height if for some reason your height bothers you. I've never really cared about height, but then again, I'm over 6 foot, so maybe that's mine. Yeah, I don't know. Well, I mean, I have plenty of girlfriends who are like 5 foot. You know what I mean? I care about height. Bone growth. Interstitial growth, we said that's growth in length. It happens at the epiphyseal plate. And we're going to look at these different layers that we're going to see here as it begins to develop from the epiphysis down towards the diaphysis. Appositional growth is thought more of as depositional growth, where we're growing in thickness or diameter of an actual bone. Here you can see that nice line right through there. That line right? That's the epiphyseal growth plate. And if you notice, you'll see it's on both sides of this joint, and it's also in the fibula as well too. Now, at that epiphyseal growth plate, we can see that there's these 4 zones of growth. The first one, which would be like up here proximal, is a zone of resting cartilage. That cartilage isn't doing anything, it's taking a siesta, okay, waking up tomorrow. The next zone is the zone of proliferation. These are the guys who are getting to work, they're going out and doing something, and they're multiplying. So they're undergoing mitosis, so they're proliferating. The third zone, which we see right through here, this is the zone of hypertrophic cartilage. Remember, at this point, we're not increasing in number of cells, we're increasing in the size of the cells. So remember, hypertrophy means we're growing in the size of something, not increasing in the number. And then finally, we get to our zone of calcified cartilage, where the cartilage actually becomes long. We want to know what these 4 stages are. You likely would get a question like, which of the following is the 3rd stage in interstitial bone growth? We okay with that? Here you're going to see details about each one of these. I really don't care if you know all these details. It doesn't matter to me. I just want you to know the 4 different stages. Okay? 4 different stages. So on these next few slides, you're going to see intimate details about what's happening in each one of these. I really don't care about those. I'm just scared that you know the 4 different stages. So that should be enough to help you figure out the answers to the rest of the question. So our flat and our irregular bones develop via plane. Our flat and irregular bones develop via plane. Intramembranous ossification. Right? Intramembranous ossification. In interstitial bone growth, there are 4 stages of ossification. We need to know all those stages. What was the first stage? Resting. The very first stage is rest, because you need some sleep. Okay? If you want to do well on your final exam, your first stage is going to get some sleep, right? But you've already been studying, right? You've already been working the entire term. Now you need to get some rest so that you can actually perform well and have the bandwidth to do well on this test. Let's see what's another review question for us. The other ones you're probably going to have to practice. You're going to have to know the different stages of intercondylar and intermembranous ossification. You need to know those stages as well too. You have some factoids here. We have some factoids here. The clavicle is our first bone to start ossification, and the last one to stop at about 33 years of age. Most of our long bones are going to completely ossify between 14 and 19, but sometimes you'll see bones like the sacrum not completely ossifying until like 33. So sometimes there's bones that will continue to develop. You can do cadaver studies, and so you may be reading a report that says that this cadaver was not completely ossified. Maybe the cadaver in question was like 33 years old, and that's not uncommon to see. Yes. I don't know if I would say that it necessarily has. I'd say it's just the general shape of the bone and its location, and the fact that it's stabilized by another bone underneath it. Like if someone's going to break a board, you want to hold that board nice and firm, right? And then the person's force will go directly to the board. But if you hold it nice and loose, it'll just like knock the board out of your hand, not break it. Clavicle is like immediately underneath the rib, so it's got a nice stabilizing force underneath it. And then the other end is held in place in this AC joint. So you've got two ends of a stick. And if you take a stick, two ends that's relatively thin, it's pretty easy to like hit it and break it, right? So I would say that it's general location, maybe not necessarily the length of time it takes to ossify what contributes to the break. It's just in a great landmark for us to be able to easily hit it. It's like a self-defense or something. All right, let's see. I think that's. Oh no, after you gotta get to the six. Why did I think that was it? I swear someone's like going in and moving around my slides. So I don't know how often that's happening. I think I've been teaching this class for like 4 years now, and I know that this is not the way it was. But then suddenly it happened at the end of the presentation. I don't know how that's weird. We need to know these 4 stages of appositional bone growth. We need to know that the osteoblasts essentially form these ridges that run around an artery. Remember, the artery is the nutrient. It's essentially creating a supply line. It's a little bit like if we were going to build a village somewhere, we want to find a nice running water source, right? So we find a good running water source, and then we build kind of close to where the stream is passing through so that we can have some running water in our little village. So again, the first step is the osteoblasts are going to form ridges that surround this nutrient artery. And then those ridges are going to completely fuse together. That periosteum becomes the endosteum. Where's the endosteum located? Inside, right? Inside the central canal. It's lined with that endosteum. The osteoblasts are then going to begin to build more layers, and that's where we're going to see the formation of the osteum. Step 3, those osteoblasts begin to produce the circumferential lamellae to thicken the bone. Now remember, concentric lamellae was surrounding the what? Concentric is surrounding the individual osteum. So here we have a concentric lamellae, right? Circumferential lamellae, that's surrounding the entire bone. So circumferential lamellae that we're seeing being formed here in stage 3 for appositional growth, that's surrounding the entire bone. And then this process just keeps on repeating to increase the diameter of the cell. As it happens, we're going to see inside a little bit of spreading from osteoclastic activity to the osteoblastic activity. So again, this enlarges from the medullary cavity and then grows out. And that maintains proportions of that inside marrow cavity and allows for an increase in the actual marrow that's inside there as we need it. What affects bone growth? What's something you know that affects your bone growth? Calcium, right? Our calcium and availability of calcium. Vitamin D, 1,2,T5, 1,2,5, we need that as well too. Vitamin D helps transition it into there. Vitamin D is something that you can supplement, right? Vitamin D is implicated in a lot of stuff, like myelination for neurons, so neural conductivity speed and things like that. How do you know if you have enough vitamin D? You got to get a blood test, right? To test and see how much you have in there. If you don't have enough vitamin D, can you supplement with it? Yeah, my nutrition teacher, who was kind of out there, and I loved it. He was kind of out there. He's a weird guy. He studied at like the Institute of Shangri-La and things like that. His first picture of his PowerPoint was him in a Speedo, standing like this at the beach. And he looked huge, but he was this tiny 5-foot guy. So it was just so funny how he saw himself, obviously, versus what he presented himself as. But he told us that in order to get enough sunlight, we all have to walk around naked for about 30 minutes each day in the height of the sun. So in order to get vitamin D from the sun at an appropriate level, you have to walk around like that for 30 minutes a day, which honestly I think compared to me feels good. All right? But you can get a lot of trouble for that, right? Okay? You can't go to your park.
Only
if
if you're
Spain,
cold.
I guess you can do that. I didn't know that. That sounds like a fun trip.
You only
But
get
can you supplement with vitamin D? Like, let's say that we live in Alaska that has, like, days where the sun doesn't go down until like 3 o'clock in the morning, and then days where you don't see the sun for like maybe 3 weeks. Can you supplement with vitamin D and do just as well from that? Yes. Yeah, you can do that. Yeah, ultraviolet light, you can do something like that, believe it or not. You can actually get ultraviolet light through that as well, too. So there's lots of ways you can supplement. What do we need to know? We need to know these minerals, okay, because we're running out of time, unfortunately. The hormonal influence that we have here, human growth hormone, Sometimes people will inject human growth hormone to do what? Grow big muscles, right? You can normally pick it out too because the site of injection, typically that tissue will hypertrophy as well too. Like you see sometimes bodybuilders inject the belly button. The belly button's like really big. Looks like it's like its own little appendage. Yeah, this is produced by our anterior pituitary gland, and it stimulates insulin-like growth factors. Of course, people also inject that as well too. And then our sex steroids influence it as well too, although it doesn't necessarily cause the growth. Sometimes things like estrogen will actually shut down the growth. And then we may also see estrogen as being implicated as a reason why sometimes very poor postmenopausal females are experiencing calcium deficiencies. Yes?
Can, like resistance exercise actually help with like benefit of growth as well?
So great question, Ken. Resistance exercise help benefit bone growth as long as you have the appropriate minerals, right? So if you do something that's going to help increase bone density, but you don't give it the nutritional support it needs, because maybe your diet is lacking in those vitamins and minerals, it's not going to work. But if you supplement those vitamins and minerals, and you also increase your activity levels, and that could be supplementing from foods, like you don't have to get it from a supplement, it could be a food, and you increase, then absolutely that will increase bone density. It'll increase the number of cells, it'll also increase cortical thickness as well too. And if you think about it, let's say that I was 450 pounds. My skeleton is under a lot of stress and tension. So my skeleton has to be what? It's got to be super, super strong. If I weigh 80 pounds, even though someone may look at me and compare the two, they may say this person's healthy, this person's sick. But technically, the skeleton of the person who's morbidly obese in that situation is actually much stronger than the person who's like maybe 95 pounds, assuming they don't do resistance training.
So that makes them morbidly obese.
So resistance training can be anything that's challenging your body. So it could be grandma lifting 2 pounds because for her 2 pounds is heavy. For you, maybe it's lifting 50 pounds because hurling 50 pounds is no good. Like it's easy for you, right? So again, it really is dependent on what's going to challenge your skeletal system. I would say most of our patients probably using 2 to 5 pound weight, maybe 3 times a week for 30 minutes. Normally it's going to help close that gap. For some people, they might have to do a little bit more to challenge the system, especially if you're younger. The younger you are, the more challenge you have to do. We got to keep going. Wolff's Law. We need to know what Wolff's Law is. Wolff's Law essentially tells you that bone will develop according to the stresses placed on it. If I take my fist and every day I get up and I hit a concrete block, piece of steel, and I hit it 100 times every day, my knuckles will begin to bulge, swell, and get inflamed, but then bone will replace that swelling to protect it. So bone can grow, and it does so in the direction of stresses. So we'll see the indication of stress lines like in the femur, where there's an overlap of essentially the sacrum displacing all of the axial load to this area. And so this is a great area to see that cortical denseness as a result of Wolff's Law. Okay, so we want to know what Wolff's Law is. And I want to say it's Wolffs. The E's missing on there for some reason. And then that's it. So next week, we'll probably start off maybe just by recapping and making sure we're all aware of where our final thing is. I will post that information on Blackboard as well too for you. Don't forget, if you have questions about things, we're still available.